Hello, my name is Nick Johnson. I'm Vice Chair of Research and Associate Professor of Neurology and Human and Molecular Genetics at Virginia Commonwealth University here in Richmond, Virginia. It's my pleasure to spend a bit of time here today with you talking about FSHD. I'm delighted to see such a wonderful conference come together and excited to hear some of the other talks. But my goal today is to speak with you a bit about how the clinical presentation of FSHD and how best to manage it. And we'll go through the next few minutes talking about that. These are my disclosures. So we'll start really with talking about the diagnosis, clinical features, then move into associate testing and some of the treatments that has been previously described. In terms of the diagnosis, there was a bit of overlap from the last talk with Dr. Harms, but hopefully that redundancy is welcome because the genetics can be quite complicated. So let's talk about the diagnosis of FSHD1. It's an autosomal dominant condition, as Dr. Harms pointed out, and has a prevalence of about 1 in 20,000, making it about the third most common form of muscular dystrophy. What's important to know about particularly FSHD1 and likely FSHD2 is that as opposed to some of the other forms of muscular dystrophy where you can see that the disorder gets worse between generations, here in FSHD, we know, in fact, that the repeat length, the contraction on the D4Z4 repetitive element is the same between generations. And the work that I'm showing you here is work done by my colleague, Kevin Flanagan, when he was at the University of Utah, now at Nationwide Children's Hospital. And what he, in this large family with multiple generations of FSHD, he was able to show across, say, 4 or 5 generations that, in fact, at every generation that the repeat length is inherited the same. The contraction seen is the same between different generations. And so that means that, it can be predicted that basically, since it's an autosomal dominant condition, there's a 50-50 chance of inheriting it from the parent who has it to the next generation, and that within that generation, it's assumed that the contraction length is about the same, and therefore the symptoms are roughly the same. Now, there's an awful lot of variation, and I've seen that personally in my practice. I'm sure many of you who are listening to this have seen that personally amongst you and your family. But that being said, the contraction length itself is the same. So how do you diagnose FSHD? That's really the first step here in terms of thinking about the diagnosis and management of FSHD. This figure that I'm showing you here is from Catherine Wagner's Continuum article in 2020. And again, I know Dr. Harms covered this in great length, but I'll highlight a few points as we go through, what the different diagnostic approach might be. So in my practice, if I see a family member and we know that, say, their parent has FSHD and they're coming in and they have all the signs and symptoms of FSHD, or even some of them, we assume that that's going to be FSHD, and we often won't do genetic testing on every member of the family. We don't do that, number one, because it's expensive and somewhat time-consuming in terms of waiting for the delay in diagnosis. And secondly, frankly, it's not for current clinical management, it's not necessarily required. As I said, we know that's an autosomal dominant condition, and we make a very strong assumption that, if your father had FSHD and they had a genetic diagnosis showing that they had 8 repetitive elements, and you have signs and symptoms of FSHD, there's a pretty good chance that you have about 8 repetitive elements as well. So one common way to diagnose FSHD is frankly just to see who else in the family has the condition and make a clinical diagnosis based on the signs and symptoms. In terms of doing the actual diagnostics, there's a couple different approaches that people have taken. Most people do some sort of blood test for the D4Z4 contraction. And if you look at the figure on your right, you can see that normally people have between 11 and 150 D4Z4 repetitive elements. and that in FSHD1, you lose and you have a contraction that shortens the overall number of those repetitive elements anywhere between 1 and 10, 10 being the cutoff, and those with 11 are assumed to not have FSHD. And once you shorten those repetitive elements, you have hypomethylation, which allows toxic transcriptal DUX4 to be expressed and cause damage to the muscle tissues. We'll go back and forth between FSHD1 and FSHD2, but while we're here for a minute, just to remind folks that in FSHD2, in fact, there's no contraction in the repetitive elements, but rather there's hypomethylation, which are these blue dots here, across that repetitive element, typically due to a mutation in a gene called SMCHD1, which is a methylation gene. At the end of the day, the result is the same in that DUX4 transcript is released, causing damage to muscle tissues. So most people, particularly with FSHD1, will start with that D4Z4 contraction, and that provides, basically will provide the diagnosis of FSHD1. Sometimes, if that's negative, people will move to doing an SMCHD1 gene test. And I will say, as of the time of this recording, that there's a couple different free programs for all muscular dystrophies, and within those free programs, the SMCHD1 gene test is included in a number of them. So sometimes we'll see somebody who we think has something like limb-girdle muscular dystrophy or a different form of muscular dystrophy, and then we'll do that genetic testing. And in fact, it shows a mutation SMCHD1, which would be consistent with FSHD2, assuming that the clinical signs and symptoms are corresponding to that. If those two things fail, the definitive test is a methylation assay that's performed over that region. At the end of the day, you cannot have FSHD, to our knowledge, without hypomethylation of this region for one reason or another. And so that's certainly the most definitive test in terms of getting to a diagnosis. Some people will do these in sequence, and some people will do all these three tests together. Of course, that practice varies widely. Any approach is actually perfectly acceptable as long as your physician is aware that if they do the blood test for the D4Z4 contraction, and that's negative, it still may be FSHD, could be the FSHD2, could be, even related to one of the less common mutations in a methylation gene, and the definitive test is that methylation assay, if it's appropriate. So one of the questions that kind of falls from getting the first diagnosis is, all right, so specifically for FSHD1, how important is the repeat length? You get a test result back saying that essentially that you've got 3 repeats or 8 repeats. How important is that? So I like to think about these in bins. What I'm showing you here is some data that was performed by the European groups here, showing that overall the number of D4Z4 repeat units in the FSHD clinical score, which is a measure of disease severity. And here you can see, and then they've also kind of in a 3-dimensional way looked at whether or not people had early onset or were either age matched or duration matched. And what you can see is that if you have less than 3 repeats, you will often have a more severe FSHD clinical score and also have an earlier age of onset. And so what that means, and we'll come back to this when we talk about some of the other complications, is that typically people with repeat lengths between 1 and 3 are more likely to have a more severe phenotype. And what does that mean? That means they're more likely to lose ambulation, they are more likely to have an earlier age of onset, and they're more likely to have some of the other complications associated with the disease. Also on this figure, I think, or I hope you can see that in fact, once you get over 4 repeat units, there is a very, very modest correlation to the overall disease severity, and that oftentimes there's really it's really not very predictive. So my personal preference in practice is to not make a big deal about whether or not you have 4 or 5 repeats or even 8. That really, there's a modest correlation in terms of their overall severity, but really separating out that 1 to 3 repeat units as a more severe phenotype is probably the most appropriate thing that we can talk about. Part of the reason for that is that this may actually be affected by modifiers in other methylation genes. So we already talked about how SMCHD1 by itself can cause hypomethylation of the region, and that can lead to FSHD2. Sometimes, and this has certainly been reported on multiple occasions now, people can have both mutations in SMCHD1 or other methylation genes and have the repeat contraction associated with FSHD1. And in that case, anything that can make the methylation worse or hypomethylate will certainly cause the disease to be more severe. So this is part of the story. There's a lot more that I know scientists are working on in terms of understanding disease modifiers for the condition, particularly as it relates to hypomethylation, but that's part of the reason why the repeat length by itself is not overly predictive. So FSHD1 or 2, we've kind of talked a little bit about the difference in the genetics. What's the difference clinically? These are genetically distinct, but the bottom line is clinically there's no identified difference. So here, this paper from Dr. Sacconi and others is looking at, again, clinical severity score, which is that kind of aggregate severity score, looking at different repeat lengths of FSHD1 and then FSHD2, and you can see by and large that there's very, very little difference in terms of the clinical severity across the board in either FSHD1 or FSHD2. I personally can't tell when I see somebody in clinic whether or not they have FSHD1 or 2, and that's because at the end of the day, it's related to DUX4, the same pathogenic mechanism, and that leads to the same basic clinical phenotype. Lots of difference in the genetics, and I suspect that we may end up in a place where some of the treatments may be slightly different, depending on how much they're targeting different parts of the genetic phenotype, but clinically, no difference whatsoever. So what is the phenotype? I think many of you who are listening to this are well aware of this, but to make sure that we're all on the same page, FSHD has a very characteristic pattern of weakness that makes the diagnosis fairly straightforward. Often there's weakness of the facial muscles, followed by weakness of the scapular muscles, which is that scapular wing, that bone that's kind of sticking out the back of your shoulder, and then weakness of the humeral muscles. And then, of course, it's a progressive condition causing weakness of the perineal muscles, particularly the muscle that helps you raise your foot up, and then the quadriceps and abdominal muscles. So what does this actually mean for you? There's a couple of points that are worth making. As opposed to other forms of muscular dystrophy, FSHD is by and large asymmetric. So oftentimes there's one side that's more affected than the other. It is hyper-regional and hyper-focused. And so by that, I mean that often the scapula can be affected and this muscle here, but the deltoid right in between them can be spared. And that to the extent that physical therapy or other devices can help optimize that kind of support those muscles that are preserved can be helpful. But I think why it's so specific is an excellent question and certainly a subject of research both in the past and in the future. There are a couple other points because it affects the abdominal muscles. People with FSHD often end up with a bit of a protuberant abdomen despite the number of sit-ups that you're trying to do. It's frankly part of the disease, unfortunately. And it is stepwise. We'll talk a little bit about what progression looks like, but it's certainly not what we consider linear progression, as you see in some of the other forms of muscular dystrophy. It is predominantly a skeletal muscle disease. So this is work that was done at the University of Rochester, which is a cross-sectional survey of 328 participants with FSHD, and it's looking at by series of different themes. What's the most impactful? What impacts you the most? So this is straight from people with FSHD. You can see, no surprise, problems with shoulders and arms is the most impactful thing, followed by limitations with mobility and walking. But if you kind of keep going down, you can see that most of the initial ranking of symptoms has to do with the muscle weakness that comes with FSHD. There are other complications. So pain in FSHD, particularly back, shoulder, and abdominal pain, is quite common, can be quite severe, can be debilitating in and of its own right. I think it's often an under-recognized feature of the condition. It's something that we talk about in my clinic. I'm hopeful that you are able to raise that with your practitioners or whoever you're seeing for your clinical care, because there's certainly medicines that we can use to treat it, and it's a big deal and certainly affects quality of life. Hearing loss comes with FSHD. It's usually fairly minor hearing loss, but it can be more significant. There are less common complications. So there's a particular retinal vasculopathy called Coats disease. That is almost always seen in those individuals with that 1 to 3 repeat links. So it's much less common. It's more common if you have the more severe repeat contraction FSHD1. There are a certain percentage of patients, a minority, that end up developing some breathing problems associated with the FSHD that can be treated often with non-invasive ventilation if it's required. One of the things we do in my clinic is that we screen for that at the beginning, and then we kind of follow along and see how much we need to manage that. So what's the natural history of FSHD? It is a slowly progressive condition. Progression is really measured in months to years, not in days to weeks. It is a bit unusual. It's stepwise, so to speak. So some other forms of muscular dystrophy, like I said, day over day and week over week, the progression is roughly the same. But in FSHD, that progression is periods of plateaus and then periods of what can really feel like catastrophic progression. People feel like they're really losing function quite rapidly. To the best of my knowledge, we don't quite know what triggers those periods of progression. It may be related to the kind of periodic expression of that DUX4, but that certainly needs to be better understood. But I think and it's also not clear what stops those periods of progression. But by and large, it has this kind of stepwise feel to it. And it's really, it can be, like I said, hyper-focused, and that progression can really be occurring in one muscle at a time. So just in one biceps or just in one quadricep muscle at a time. So, I think we like to continue to monitor and certainly support that as much as we can. Unfortunately, there's no treatment currently available that changes the progression of FSHD, but I'm super hopeful that you're going to hear a lot of great talks throughout the rest of the meeting and elsewhere that indicates the amount of work people are doing, trying to develop those therapies that can change the rate of progression in FSHD. And I'm hopeful that, like I said, in the next few years, we'll have a different slide here that talks about the different therapies that one may be able to offer. There are other associated testing that people will sometimes do for FSHD. Muscle MRI, which is what I'm showing you here. This is a whole body MRI from Johns Hopkins University, or the Kenny Krieger group, indicating a good way of actually measuring what that progression looks like over time. Because you can actually see the fat and scar tissue come in and replace the muscle as the disease progresses. And that what you can see here is a series of muscles and the amount of fat that's seen in those muscles across different people. And you can see that it's quite scattered about the amount of fat that's replaced there and what that actually means for those patients. This is not commonly used in clinical practice, but rather really is commonly used in terms of research and measuring progression that way. And the only reason it's not used in clinical practice is because if we were to see a change associated with that progression, unfortunately, like I said in the last slide, there's not currently a therapy that we'd be able to offer that would be able to reverse that. On the research setting, that's a different story. But I think for now in clinical practice, this is not commonly used. Some people, particularly if they weren't sure that it was FSHD, may have had a muscle biopsy for diagnosis. In FSHD, the muscle biopsy may look quite normal, not show any changes whatsoever. It can sometimes show changes associated with inflammation if the right muscle is biopsied. That can sometimes be confusing for clinicians. But by and large, the muscle biopsy is not particularly helpful in terms of the diagnosis. It's often done because somebody thinks that they might have a different form of muscular dystrophy. Okay, let's talk a little bit about treatment and start by talking about assistive devices. So there are certainly things that we can offer when you come to the clinic to help you modify and support ambulation as much as possible. Those things fall into a couple different categories. One is ankle foot orthoses. So one of the biggest deals in a big safety issue is that as that calf weakness gets worse, people can lose the ability to kind of bring their ankle up as much as they need to when they're walking. That can cause trips. Those trips can lead to falls. Those falls lead to broken bones. And of course, if you're laid up in a cast or in a hospital with a broken bone, and not able to continue to use your muscles, that's a big deal and can lead to progression in its own right because of the muscle atrophy. So when we see that people are tripping or even if they're falling, we'll often recommend ankle foot orthoses to help prevent that from happening, and that will prolong your ability to walk for as long as possible. Canes, similarly, can be quite helpful in terms of stabilizing these things. And then finally, in some people, you'll need a motorized wheelchair or a scooter to help get around. And this slide that I'm showing you here is from the University of Rochester's FSHD myotonic dystrophy patient registry. So they show both myotonic dystrophy and FSHD, but just to focus on out of the 400 or so patients that they have in their registry, about 11% using a leg brace, about 32% requiring a cane at the time of the survey back in 2012, and about 30% or so need a wheelchair. So it's not like you get a diagnosis of FSHD and need a wheelchair the next day. It is commonly needed, particularly later on in the progression. And there's, like I said at the beginning, depending on the genetics, there may be other factors that would promote the earlier progression and need for a wheelchair versus later use. Exercise in FSHD, hot topic. I get asked about this a lot. I think the take-home message is this. Aerobic exercise of moderate intensity has been shown to improve endurance and reduce fatigue. And so what does that mean? What is aerobic exercise of moderate intensity? That means that you should be, feeling like you're exercising, you should break a sweat, you shouldn't be able to read War and Peace out loud when you're exercising of moderate intensity. But you shouldn't, push it so hard when you're exercising that you can't get out of bed the next day because you're so sore. So you want to find that moderate intensity zone. Moderate intensity zone is different if you're 20, if you're 40, and if you're 60, if you're early in your disease or late in your disease. And so I think, I don't often recommend that everyone needs to be swimming or biking. I think the important thing is the amount of exercise. So, 30, 60 minutes, and then also, that you're kind of staying in that moderate zone. I do advise caution with weight-bearing exercise or heavy weight loads. Because of the muscle atrophy and weakness that occurs, particularly in the shoulders and hip joints in FSHD, if you're applying a lot of torque on that joint with a heavy weights, you're trying to lift, 50 or 70, pounds barbells, you can really cause some damage to the joint, into the nerves, because those muscles aren't there to help support that, and you're highly reliant on that joint to bear the weight load there. So there's been a couple different slides, or excuse me, a couple different studies that have looked at FSHD in exercise. The figure on the right to support the first point comes from work that was done by Bissing's group in 2005. In there, they're basically doing aerobic training, and you can see they're looking at whether or not these different features got worse, were unchanged, or improved. And you can see that some improvement in fatigue, some improvement certainly in endurance and strength and level of activity, although some people did actually get a little bit worse with their level of activity once they were doing aerobic exercise. So this is a high level, certainly worth checking in with your practitioner about whether or not it's exactly right for you and what type of exercise you might want to do depending on where you live and what your stage of disease and who's there to support you. But by and large, aerobic exercise has been shown to be helpful for FSHD. Another thing that sometimes people ask about is scapular fixation. And so this figure shows what essentially happens. So with FSHD, you get the scapular winging, and that comes with decreased ability to raise your arms over your head. And what some surgeons have figured out is that they can basically sew the scapula onto the back of the rib cage there to fixate it there, to kind of hold it steady, which allows these muscles below this deltoid muscle to work a little bit better. This surgery is beneficial for a minority of patients, I would say. You can often tell who's going to benefit from this surgery with manual fixation of the scapula. So when I see people in clinic, I'll often kind of manually fixate the scapula. It's pretty obvious whether or not somebody's going to benefit from this surgical approach because their arm goes up quite a bit. So I think if you see the amount of sewing that happens, it's not a minor surgery, it's a larger surgery. So you want to make sure that you've got the right patient who would benefit from it and wouldn't do it unnecessarily. But in some patients, like I said, the minority, it may improve shoulder range of motion in appropriate patients. So in terms of medications, there's no current therapy that's been shown to be a benefit. There have been studies that have denied the benefit of using albuterol, corticosteroids, and myostatin inhibitors. I hope, like I said, you're going to hear promising news from clinical trials that are ongoing, both now and in the future. There have not been studies that have specifically supported supplement use, although typically the supplements people use are not particularly harmful to them. And then treatment of pain with standard therapy. So for me, that's things like ibuprofen or Tylenol, or the next level would be things that people would typically consider using for fibromyalgia, like gabapentin, Cymbalta, Lyrica. I tend to avoid opioids as much as possible because the pain that comes with FSHD is going to be with you for a long time, unfortunately. And so it's important to be on something that you can continue to take and minimize the addictive properties where possible. In terms of clinical monitoring, it's important that you come and see a neurologist at least once a year, if not more, to check pulmonary function at both baseline and should symptoms develop that would make you think that you would want to check it. Retinal monitoring in appropriate patients, again, those more severe repeat contractions, will often screen for pain and hearing loss during the clinic visit. And those are kind of the important things that happen during that clinical visit, aside from getting more knowledge about the research possibilities that are ongoing. So in summary, diagnosis is often done by blood test to look at that D4Z4 contraction, SMCHD mutation, or methylation. Frankly, sometimes just by family history and clinical symptoms is sufficient. The repeat length may predict severity, particularly at those lower lengths. Aerobic exercise may be beneficial, but current medications are not disease modifying at this point. And that's all I have in terms of talking about managing FSHD, and I would welcome any and all questions.